complete hemodialysis series, many complications we have discussed in the previous parts. Today we will see regarding a not an uncommon complication in the dialysis unit, that is seizures during dialysis. Seizure in any form, most commonly tonic-clonic type of seizure. Since dialysis involves electrolytes, patient cross fluctuation in the any parameter can occur. BP can shoot up, BP can go down, patient might not tolerate the clearance, or due to any etiology the patient can develop seizure. First of all, to manage that particular seizure, at least 2 to 3 member team might be required. Most importantly, what are the steps to follow? As soon as patient started having the tonic-clonic movements, all of a sudden, first is we have to make sure patient airway is not compromised. We have to put the patient in lateral position so that aspiration won't happen. Tongue bite should be prevented. How to do that? Any soft object can be kept in between the teeth, and also head and have to be bit elevated. This is the first and foremost, so as to avoid any aspiration. Second, suppose if the helping staff is there or 2 or 3 persons are there, meanwhile one person is handling this aspiration part, the other supporting staff should focus on securing the vascular access. The dialysis is to be stopped, but before that, what is the problem which can happen is, if the patient is on AV fistula and the needle are inserted and dialysis occurring through the fistula, what will happen? As soon as the patient started having that movement, needle will go and prick anywhere. The fistula will get damaged permanently. Because of this short episode, the fistula will go for a permanent damage. Why? The needle is placed with the help of some sticker, Dynapar, micropore, whatever it is, we are sticking it. Inside it, there is no control. As the patient started having the movement, it will go and counter prick the vessel. As soon as the counter prick occurs, what will happen? The blood will start leaking into the subcutaneous space. And also, if the prick is near the arterial side, the swelling can be big. This is the problem if the patient is having dialysis or getting dialysis through the fistula. The second one, suppose if the patient is getting dialysis through the catheter, what can happen? The catheter can come out, or if the movement is violent, the catheter can totally dislodge. So first and foremost is to secure the AV fistula and also the dialysis catheter. Both have to be secured. The nursing staff have to go and catch hold of that vascular access so that it won't get dislodged. This is the second one. Third, stop the dialysis. Suppose if you are going directly and stopping the dialysis, what will happen? This will go for a clot. The time the second nursing or supportive staff is doing that securing the vascular access part, the third one should come and make sure this is getting circulated. The blood which is in the dialyzer and the tubing is getting circulated, because if the pump is not moving, meanwhile in that 5 to 10 minutes the entire blood will get clotted. So the blood have to be put into circulation. So this is the important part on this side. On the machine side, this have to be taken care of. So vascular access we have secured. If fistula is there, that we have to make sure that is not getting damaged. Airway breathing we have managed. Then what next? Two things can happen. This seizure can be for a short period, 2 to 3 minutes, it might resolve, or the patient might continues to seize. The tonic-clonic movement might be continuous to occur. So this is the time after securing the airway, and this one you have to give short-acting benzodiazepine like midazolam, lorazepam, diazepam. These also can be preferred at a lower dose. What is the dose to be given? Those and all patient specific. and also how much dose the patient can tolerate, that will decide. As a duty doctor in the dialysis unit, I hope you might be knowing the dose and all. A short acting benzodiazepine have to be given immediately. That will reduce the seizure activity. Once the seizure activity is reduced, we have to evaluate the cause. Cause can be numerous, which is similar to specific and non-specific, specific to dialysis, non-specific to dialysis. That and all we will evaluate. But in the dialysis unit, immediately what to do? Immediately check the blood sugar. Hypoglycemia is one of the important parameter which can cause seizure. So sugar have to be checked. If like this monitors are there, pulse, saturation, ECG have to be done, or the patient have to be connected on the monitor. These basic steps have to be done, and the on-duty doctor can be called, because during the seizure, the on-duty staff or the nursing supportive staff might not have time to call the doctor to manage what drug to give and all. So first of all, secure the patient, access, stabilize them, make sure the patient is not aspirating. Once these are done, once subsequently the team is arrived, then you can manage the further step, like giving the further anti-epileptic drugs. For the MD resident or the PGs or the PG aspirant who are seeing the video, you might be having doubt, sir, what is other common cause of this seizure, especially during dialysis? One important parameter, as you see, this dialyzer can remove the drugs also. Suppose if the patient is on any particular anti-epileptic drug, if the drug is removed during dialysis, patient can develop seizure. With respect to that, try to find out what are the drugs which can be cleared out during the dialysis. In total, commonly if I have to tell, dialysis disequilibrium syndrome, hypoglycemia, hypertension, any electrolyte abnormality, CVA, these are all things which can cause epileptogenic seizure during dialysis. So that's all. At least in this video we have seen the general parameters, how to manage, especially during dialysis. In our unit or in our experience, what are the common problem we have seen? One is AV fistula damage, another one is entire circuit being clotted, third one the catheter being coming out, catheter getting damaged, or excessive blood loss. If the focus is kept only on the tonic-clonic movements, on one side blood loss might be occurring. So these are the common problems that we have encountered. So this is how the general management should be. That's all. Bye bye.